This presentation is on alcohol exposure during pregnancy, and I will also be discussing fetal alcohol spectrum disorder. A little bit of background on alcohol exposure during pregnancy. According to the ACOG, that there is no amount of alcohol or type that is safe to consume during pregnancy. Alcohol use is linked to miscarriages, stillbirths, preterm labor, and SIDS. It is also linked to fetal alcohol spectrum disorder, which can lead to lifelong physical and mental health problems. There is an estimated of 1 to 5% of children in the United States that by first grade, they are noted to have fetal alcohol spectrum disorder affect. Some other factors that are likely to increase the risk of drinking during pregnancy would be increased stressors, socioeconomical status. Typically, a patient that is seen in the older category, meaning ages 35 to 45, are more likely to drink during pregnancy, and then their location. If they're living in more of a rural versus an area that's more saturated with healthcare, there certainly seems to be more instances of drinking during pregnancy. Now, national epidemiology. The incidence, according to the National Survey of Drug Use and Health, 11% of women ages 15 to 44 reported drinking during pregnancy in 2022. This is very similar to what the CDC reported in 2019 to 2022, which is 14 to 15%. About 1 in 10 reported alcohol use, and 1 in 22 reported binge drinking. In 2018 to 2020, overall, 13.5% of pregnancy-related deaths were related to alcohol use, and 5.2% were related to binge drinking. Now, the next couple of slides go over the morbidity rates in the U.S., and this is from the CDC in 2020. I won't go too much in depth, and I'll certainly leave this for you guys to review, but overall, the left-sided column just shows the characteristic. Then it shows who is current drinking rates for during pregnancy, and then binge drinking rates. And then it also goes over race and ethnicity, education status, employment status, marital status, as well as if they are seeing a healthcare provider frequently and if they have any mental distress as well. Specific to Massachusetts, the CDC reported in 2022 an average prevalence of 16.4% of alcohol use during pregnancy. The DPH has reported in the same year that about 61.5% of Massachusetts mothers reported drinking alcohol within the 3 months prior to getting pregnant, and 26.7% reported binge drinking in that 3-month period before pregnancy. They also estimate that 1 in 5 pregnancy-associated deaths were related to substance use, which does include alcohol. So overall, that percentage is about 4.9% of substance use, and alcohol was about 1%. And it has an estimated 2 to 5% of the children who are born do have FASD. Now, some maternal risks for drinking during pregnancy would include preterm labor, miscarriage, hypertension, increased risk for nausea and vomiting, which would lead to nutritional deficits and dehydration, gestational diabetes, increased risk for STIs. Prior to pregnancy, it could increase the risk for unplanned pregnancy as well as altered fertility, increases the risk of injuries overall, especially during pregnancy, seizures, cardiomyopathy, and certain types of cancer. For paternal risk, ETOH consumption prior to conception increases the risk of birth defects and behavioral issues in offsprings. In 2021, JAMA Pediatrics found that couples who consumed alcohol prior to conception had a higher rate of birth defects, especially cleft lip. Fetal risks include preterm birth, birth defects, low birth weight, neonatal abstinence syndrome, and fetal alcohol spectrum disorder, which I'm certainly going to go into more detail. This is just kind of a brief overview of what it's characterized by. It's an umbrella of disorders. where they can have abnormal facial features, growth issues, central nervous system abnormalities, learning issues, memory difficulties, short attention span, trouble communicating, and hearing and vision issues. Some clinical suspicions would be noticing those facial abnormalities, intrauterine growth restriction, microcephaly, recurrent non-febrile seizures, developmental and learning cognitive issues, behavioral issues, and social and emotional problems. Now, the effects of fetal alcohol disorder can vary considerably depending on the amount and timing of exposure of alcohol in utero. For example, facial characteristics such as small eyes, thin upper lip, short upturned nose, these often occur with exposure of alcohol in the first 12 weeks of pregnancy. And there are different categories of FASD, which are based on the features, and these include fetal alcohol syndrome, partial fetal alcohol syndrome, alcohol-related neurodevelopment disorder, alcohol-related birth defects, and neurobehavioral disorders associated with prenatal alcohol exposure. It's important to note that FASD is preventable. There is no cure, and early detection with ongoing comprehensive evaluation and referral to specialists and early intervention is very key in managing FASD. Here's just a image just depicting some of the physical features that might be noted in a child with fetal alcohol spectrum disorder. And then going into some screening tools that are recommended by the ACOG for patients during pregnancy. This would include the TACE, which is a 4-questionnaire tool that can be used to identify risk during pregnancy. And the scores range from 0 to 5. These are based off tolerance, annoyance, cut down, and eye opener. It has a high sensitivity of 88% and specificity of 89% to identify risk of drinking during pregnancy. There is also TWEAK, which is a 5-questionnaire tool that's used to screen risk, and these categories are tolerance, worry, eye opener, amnesia, and cutting down is the final letter K. It's very sensitive, about 93 to 100%. And then audit, which is a 10-question questionnaire. There is also an audit C, which is a condensed version of this, which is 3 questions, and this detects about 97% of alcohol-dependent adults. And then these are just a little bit of an example of each one of the questionnaires that you would administer to your patients. So here is the TACE, the TWEAK test, and then the audit, which audit is something that I certainly use in my practice quite often. Now, the presentation of patients that you might see that have been or are drinking alcohol during pregnancy, they might report issues with sleeping, feeling more anxious, having depressive symptoms. They might report having acid reflux symptoms, feeling nauseous, noting vomiting, or reported social issues such as in relation to finance, their relationships, or housing. On exam, or some objective information that you might note, is the patient having elevated blood pressure, hypertension, elevated blood sugars, electrolyte abnormalities, elevated liver enzymes, macrocytosis, and although this isn't required, you can also check a blood alcohol level, which can be helpful in evaluating severe alcohol dependence during pregnancy. Now, some differential diagnoses I did for alcohol use as well as FASD. So they're listed here, including for alcohol use, panic disorder, generalized anxiety, social phobia, depression, bipolar, and insomnia. And for FASD, ADHD, intellectual disability, oppositional defiant disorder, conduct disorder, and reactive attachment disorder. Now, for the prenatal care, the ACOG recommends that universal routine screening to all pregnant patients You would want to screen early and often and educate your patients on the risk of drinking alcohol during pregnancy. To do this, you would want to use either a validated questionnaire, or if the patient's refusing to fill out the questionnaire, just make sure you're having continued conversation with the patient and open up the conversation to the patient where they feel comfortable, if they are drinking during pregnancy, to disclose that to you. Lab testing is not required again, but in certain cases could be considered. And it's recommended to screen certainly during the first prenatal visit, so the initial prenatal visit. There's no set schedule on screening further in pregnancy, but again, you would want to ensure that the conversation is continued and you are continuing to screen those patients that are higher risk, such as lower socioeconomic class, patients that might be involved in domestic violence situations, patients with history of anxiety, depression, or if there's an unplanned pregnancy. There also can be a lot of stigma around alcohol use, especially during pregnancy. A lot of the times patients can feel judgment from their healthcare provider. They might feel shame, depression, low self-esteem, or fear of losing their child. In order to assist, you want to be aware of your own stigma and practice motivational interviewing, which would include, making sure that you express empathy towards the patient, develop some discrepancy. You want to really kind of roll with the resistance. Try not to get frustrated if the patient isn't open to talking to you about it, and continue just to have open conversation and support self-efficiency. We want to help patients open up and just be careful to not have judgmental attitudes. If a patient refuses, it's important to just make close follow-up to ensure that you can continue that conversation. Now, some other factors just to take into consideration with psychosocial, you would want to take into account that there can be unplanned pregnancies, loss of relationships, involvement with sexual assault or domestic violence, history of child abuse and neglect, history of driving under the influence, altered judgment, and some financial strain. Some physiological factors to take into consideration is that alcoholism can be linked to genetics, so getting a good family history can be extremely helpful in identifying alcohol use during pregnancy. And then some psychological factors would be increased stress, especially during an unplanned pregnancy, anxiety, depression, any suicidal ideations. And you want to be able to ensure that you're screening patients with a PHQ-9 and or a GOD-7. And I'm sure this will be going over in other of the presentations this week. Now, there is certainly different kind of interventions you would want to take into account. So for patients with mild to moderate cases, mostly can be managed by initiating brief intervention, which would include providing an assessment, such as administering a validated questionnaire, as I reviewed previously in this presentation, giving the patient direct feedback, setting goals with the patient, using behavior modification techniques, assisting the patient with local resources such as self-help resources and support groups. This can be a very cost-effective way and can be done in a variety of settings. And it's important to know your local resources. And I listed some resources that are local in Massachusetts here. Now, lastly, I just want to go over some legal aspects to take into consideration. It is important to be aware of your state regulations, as many states have mandatory reporting. There are some states that have laws in prosecuting and incarcerating pregnant women for the use of drugs and alcohol. Some of the non-reporting states are listed here, just for your review. Outside of these states, the remaining states are reporting states. Massachusetts is a mandated reporting state where healthcare workers, social workers, and law enforcement are mandated to report the use of alcohol during pregnancy with a referral to child welfare agencies. So just to close, again, it's really important just to make sure your patient is educated and you're keeping that conversation open if there is an instance where a patient seems like there could be a risk of drinking during pregnancy and they're just not comfortable opening up. And then here's some resources. Thanks so much.